Currently, I'm a trainee advanced clinical practitioner within the surgical services department. I'm primarily based within the upper GI team at the moment, but it is a rotational training post. Approximately 11 years ago, I moved into medical education, where I taught medical students various aspects of upper GI and colorectal surgery and the management of the patients within that setting. Along with that, my clinical skills were maintained by working as an advanced scrub practitioner. So I went back to theatres, performed some first assisting roles, wound closures, local anaesthetic infiltration. I also ran a gallbladder clinic for patients presenting with gallstones, and then the management of those gallstones. The training post is purely a clinical post now, so I've left my education role behind. There is an element of education within the role, but it is strictly a clinical position now. The role currently is working quite well alongside the junior doctors, more the F1s and core trainees. I think because the role's still very much in development, it's quite a fluid role. I think the benefits of working as a trainee or as a qualified ACP with it, particularly at the moment within the surgical services department, the main benefits being because it's still a new role, it's still developing, so it's still very fluid. It has an awful lot of support from management and from the consultant colleagues as well. They're very keen for us to develop our skills and knowledge throughout various different aspects of patient care, from ward care to theatres and clinics. So there's huge scope for development of the role within surgery at the moment. My only concern, I guess, is with regard to non-medical prescribing, which as an operating department practitioner or as an ODP is not available for me currently. I hope that in the future that's something that can be addressed at a national level, that would then enable me to practice more autonomously in the future.
My background is a paramedic. Worked for West Midlands Ambulance Service since 2003, and then got to a point in my career where I needed to advance myself and push myself that little bit more. So I started looking around at career progression and where I wanted to be for myself. Came across the ACP role, had a look into that and various courses that are available, and came across the scheme that I'm on at the moment with Derby Hospital. We get 1 day a week release to university, whilst also working the rest of the week within a clinical background. So my background at the moment is in specialist medicine, currently based on endocrine. I have to introduce myself as a trainee advanced clinical practitioner. This often has to be explained to patients because it's a fairly new role, so they don't understand what the role is. A lot of the junior doctors, senior doctors and the nursing staff are fully aware of what our position is within the team. So we don't generally have to explain ourselves to them. It's mainly to the patients. Some of the patients see us as being a doctor, and even though when you try and explain to them that we're not and what the role actually is, they still actually say that he's still a doctor. A lot of them will actually take on board and get quite interested in what we actually do and how we work alongside the doctors to help them in their roles, and how we're working with the team with the nursing side as well. I can't prescribe as having a paramedic background. My colleagues that are nurses that are currently on the same programme as myself will be doing that as part of their training, and then if it does come through that paramedics can prescribe, that'll be added on as an extra at the end of my training. Because we rotate at the moment, within this role we actually get supported by a clinical supervisor, which is normally the consultant that I'm working with on that particular ward, and an education supervisor. Both of mine have been really supportive so far, helping me with aspects of work on the ward, and also with the education side. If I get stuck on my university work, they will try and help me out on that front. I found the transition from pre-hospital into hospital quite hard to get my head around, with why things are done differently and different expectations. I found it harder than I thought it would do, but I feel that it's been a good thing to do, and it's been quite a positive process to go through with the aid of my supervisors. When I started this programme, we had an induction period within the hospital that was for all the ACPs that were starting within our cohort. So they did actually try to help to integrate us within the hospital system, so it has made it slightly easier.
My background is that I am a physiotherapist. I've qualified in 1993, and I did 13 years as a physiotherapist, mainly specialising in outpatients when I became a senior physiotherapist. So within the role as a trainee advanced clinical practitioner, I'm enjoying the role. I do find it quite challenging, which is one of the reasons that I came to do the post in the first place. The challenging things around it is mainly kind of trying to fit everything in that I need to do in the time that I've got. So there's not enough hours in the day really. So mainly because I'm working full time, and then I'm having to do a part-time master's degree on top of it. So I'm having to juggle working full time, doing a lot of study at home. And then there's a lot of competencies that we have to fulfil. The specific area that I'm working in at the moment is medicine for the elderly. My role differs from the junior doctor's role at the moment, not vastly, to be honest, because of the background that I have and the experience and knowledge that I brought into the job with me. What they've tended to do with me is that they've actually fast-tracked me a little bit. So the first module that I did at master's level was my prescribing. So I was only actually supernumerary for about the first 9 months since starting as a trainee advanced clinical practitioner. So for the past 10 months I've actually been included in the doctor numbers. So I'm doing a lot of the same jobs that a junior doctor would do now. But where I do differ is that obviously once I've seen a patient, if I've got any concerns at all, then I need to go and chat it through with one of the other doctors to help me make some clinical decisions and prescribing decisions. And obviously there's some clinical skills that I can't do because it's out of my scope of practice, or I've not had the relevant training to do it. So I need to make sure that I get doctors to do those procedures that I'm not qualified to do. We're taught a set of core skills and competencies. So a lot of those core skills can be transferable elsewhere. So I could, for instance, go and work in a GP surgery afterwards out in the community, or I could choose to stop within the acute setting but move to another speciality. So my core skills that I've got at the moment, and once I'm qualified, I'll be able to transfer those elsewhere. There is a big difference from physiotherapy to becoming an ACP, but I think the training that we get as a physiotherapist is a really good foundation to become an ACP. So for example, physiotherapists we get quite a lot of teaching on anatomy and physiology, and we are taught to take a history and do a clinical examination of a patient, very much using the medical model. And because we're expected to work as autonomous practitioners, we're used to using our clinical reasoning skills and developing our own management plan. So from that perspective, I think it puts physios in we've got a really good foundation. But then obviously there's definite knowledge gaps and skills gaps that needs to be fulfilled in order to become a qualified advanced clinical practitioner. From when I started 18 months ago, I think within this trust there are already advanced clinical practitioners in post, and especially within Department of Medicine for the Elderly, they've been used to having advanced clinical practitioners working with them. So I was quite readily accepted into the role. But what's really interesting is that 10 years ago when I did the year secondment as an advanced practitioner within the accident and emergency department, it was very, very different then. There was a definite mix of opinions at that point, in that some people were really quite supportive and wanted to see the role develop, where there were other members of staff that really weren't accepting of it. And I got quite a few people said to me if I wanted to be a doctor I should go to medical school. So I've seen a very big difference from 10 years ago to now.
My background is speech and language therapy, working, I've always worked with adults in an acute setting. I have previously worked in community, but only very briefly for about 6 months. I've been qualified for almost 12 years and started to get to that stage where I felt I wanted to push myself. And the ACP or the trainee ACP role I'd been aware of in Derby, and I'd always sort of looked to the role and thought it was a great role. You know, I've worked with them on the wards, on the stroke ward, and I've seen what a difference they make. So when the opportunity came up that they'd opened it up to other professionals, so not just the nurses and paramedics, I was very keen to apply. So the ACP role, I think they're a stable workforce on wards that both the medical, nursing and MDT team members can work with. They often have a good view of all the patients on the wards, so they're often very good at resource to ask questions. They're very supportive. They support, you know, all members of the team, so they're mainly there to support the medical team. There's therapists sort of coming through that obviously have a different take of managing patients, so looking at patients holistically a little bit more and bringing that into the medical way of working. We're put on the Masters in Advanced Clinical Practice, which ideally should be achieved in 3 years. So this is going to university 1 day a week, which is supported by the Trust. Clinically, we are here full-time. I am full-time. So clinically as well, the expectation is that over the weeks, months and years you become much more clinically skilled. For example, learning new skills for me, you know, bloods, catheterisation, and you start to build on those skills, so you have a clinical portfolio to show that you clinically can do those procedures. There's also other aspects that we have to prove in our portfolio, so communicating with others. There's lots of competencies that we have to collate evidence for in our portfolio. I am going to be split between the Department of Medicine for the Elderly, so DME, for half of the year, and then for the rest of the year I'm going to be working across the specialist medical business unit, so beyond wards, for example, like stroke, cardiology, gastroenterology. So I'll sort of be split between the two areas. Number one is the challenges that I've got to learn, you know, an entire system. So I've got to sort of go back straight, you know, to basics about, you know, heart, cardiovascular, respiratory system. So for myself, that's going to be a huge challenge. And it's your identity, I think, because I've worked at the hospital for a long time. People have obviously been used to seeing me as a speech and language therapist. So it's trying to switch that identity to my new role, you know, still using my skills as a speech therapist and my identity as a speech therapist, but, you know, switching over to this new identity. At the moment, the Royal College of Speech and Language Therapists are trying to push through prescribing rights for speech and language therapists. It would be highly helpful for quite a lot of speech and language therapists. So at the moment, it's sort of similar to the paramedics, that it's in process, but whether we'll get those rights, I'm not quite sure at the moment. The ACP role itself, now I'm sat in that role, has, it's met all my expectations. I'm really excited. I think it's a great opportunity for myself and other possible therapists, in the future, that we can be offered this role and still be a therapist at heart, but learn more skills and be able to improve patient care, I think, is fantastic, really. My anxiety was how people perceive me. So, like I said, people know me as Lucy, the speech and language therapist, and all of a sudden I've got my red uniform on, and I was slightly concerned how other people would perceive that. But actually, I've had a lot of support from consultants, nursing staff, and I think it's because people are aware now the role is open to all AHPs, and I actually feel quite privileged to be doing the role and be one of the first speech therapists to be doing it. We're kind of a small cohort. I think there's another 3 physios, but the therapy ratio to nurses and paramedics is much less. So, but it's been a positive experience, and actually people have been very, very supportive of me stepping into this role. Patients themselves have been very supportive. The first day I'd met a gentleman on one of the wards who I'd seen previously as a speech and language therapist, and he'd recognised me, and he was very, very supportive of my new role. I think the vision is that they can have a broad range of trainee ACPs and qualified ACPs with, of various professional backgrounds, which I think is exciting, and I think it's great to be part of this workforce. But to have that variety of backgrounds, I think, is really quite exciting, because I think these skills that I have as a speech and language therapist that perhaps a nurse may not have the skills in, and I've also got knowledge that I can share with the rest of the team. So it's that multidisciplinary working and sharing of knowledge, which I find quite exciting.
I trained as a nurse in Cardiff and worked within the acute setting, and then after doing that for a fair few years, I went and worked in the voluntary sector for the Alzheimer's Disease Society, and had my children, and then essentially just worked a few bank shifts to keep my nursing registration going. And during that time I studied for a postgraduate certificate in business administration, and heard that there was a advanced practice course starting at Derby, and a colleague of mine who is a GP encouraged me to find out more, and I did that, and got a place on the course, and my GP colleague sorted out mentoring for me, and I eased myself back into work after having children more formally at that stage. I don't see pregnant women, for example, but pretty much everything else I see. And I think that it's just a role that evolves with experience. Obviously, if I need any help or assistance, then I can refer to my colleagues. I'm very well supported by the clinical team, and we take part in a lot of education. I'm actually a GP trainer as well, so we have a lot of learners within the practice. So we have a lot of clinical supervision and clinical meetings and peer review meetings. So there's plenty of opportunities to ask questions. Within general practice, obviously there's a big focus on maintaining health, keeping people well, long-term conditions, and all the minor illness and bits and bobs that come in. Obviously we also have to pick up the people that are unwell and need to be referred on to secondary care also. We have a lot of experienced practice nurses who have advanced skills, but they're in a narrower field, so maybe they would be specialists in diabetes or asthma, COPD, hypertension. So they have advanced skills, but they're in a narrower area. The ACP role is a more generic role with competencies across a far wider area. And now, as well as nurses taking on this role, we have some pharmacists that are doing this now. So I have a pharmacist colleague who is about to start the ACP training. ACPs now are being recruited from a variety of clinical roles, including pharmacists and physiotherapists, and I think speech and language within the hospital as well. It adds to the clinical mix. Every clinician brings with them their own skills and their own background, and the way they will have developed throughout their career, they will have picked up a lot of skills along the way that maybe you can't write down in a curriculum, that they're just things that you pick up, and they're all transferable and can be used. And we learn a lot from each other. It's fantastic working alongside a pharmacist because they've got wonderful instant information about medicines that I can't remember, and we can share our skills and learn from each other always. And I think that we have to make sure that we've got a benchmark set so that we are all trained to the same level. We need some standardisation so that patients know about what they can receive. Somebody who'd like to consider training to be an ACP, we recommend that they've been qualified for at least 5 years with 2 years experience at a senior level. They need to have the ability and the desire to want to be able to train and take on modules at master's level. And if they're up for that, they need to find a trainee ACP post and get on the programme and make sure they've got a good supervisor. But the role is lovely. It is very varied. There's no room for boredom, and there's plenty of things within that generic role that you can keep on learning about all the time. The ACP role within general practice, trying to explain what that is to patients can be challenging. Many of the patients in the practice that I work don't speak English as their first language. We do display information on the practice website and also within the practice on screens, and I introduce myself when patients come in, and as Julia, an ACP. Some of them will still at the end of the consultation say thank you doctor as they walk out of the room, but some patients will come in and say, oh, ACP, tell me a little bit more about that. So it is varied, and I think the message is getting through, but there is a bit of marketing to be done about the role. Having ACPs employed within the general practice does add another dimension to what's on offer to the patient. It improves their choice by giving them another clinician that they can book appointments with, and also improves the set of skills within the practice.
It was about gaining extra knowledge and extra skills. So what I was finding in the intensive care setting after I'd been there for a while was I kind of knew things that the junior doctors were doing, and I was thinking, I know the answers to the consultants' questions on ward rounds, and sometimes I'd be doing stuff that they hadn't have thought of, and I just thought, well, they got so much more knowledge, and I just kind of wanted to acquire extra knowledge and do more skills again as well. So that was a big driver for me. The big challenges of the ACP role is kind of a lack of knowledge from the general public about the role, and fellow team members. So, people either want you to be a nurse or a doctor and a physio or a dietitian, and you have to, patients, when you go to them, and it can sometimes just to do a blood test, and they say, oh, who are you then, and what are you, and you find yourself explaining yourself quite a lot, sometimes about 8, 9, 10 times a day if you've got a lot of different patients that day. And it was new on the medical ward, so you find yourself, it's quite unique because you're not stepping into a pre-existing role, so you're having to forge the role. You're trying to acquire extra skills and extra knowledge, and you're in a situation that you've not been in before, and then you're trying to be a really positive driver for the role as well, and you're trying to get doctors on board with you and nurses on board with you. So it was a massive challenge to begin with. It's gotten easier as time's gone on because we're on the medical wards for 3 years now, and each time we rotate, we just, the role's quite well established, and you hit the ground running from day one, making a difference to patients and contributing to their care, their pathway through the hospital. So in ED, you know, we can clerk patients, order investigations, get things going for them, and then they move to the medical assessment unit where we clerk them again, order any investigations, assess them, prescribe any medications that they need. And then throughout, you know, whether they go to the medical wards, surgical wards, or discharge from MAU, you know, it's about timely discharge and getting the discharge summary written, and, you know, liaising with the GPs and people in the community about any issues that have arisen during the admission. And then it's working with your fellow MDT members. So as a nurse, I know the frustrations that the nursing team have, and then as I've gotten extra skills and extra knowledge and worked closely with the doctors, I know what frustrates them. So it's about promoting harmonious working sometimes and just being that stepping stone between the two professions. And I think it's empowering people as well. So with the extra knowledge I've got, if a newly qualified staff nurse or a staff nurse has been qualified a long time, we've ordered an investigation that they don't understand the importance of, it's really nice to be able to sit down and explain, oh, this is why we're doing that. And then from the doctor's point of view as well, being someone that they can feel comfortable enough to ask questions to. The difference between a first year ACP and a third year ACP, my knowledge has definitely come on leaps and bounds about a whole host of medical conditions. So I work on the medical wards and I rotate. Originally we rotated every 6 months, and now we rotate every 4. So you find yourselves, you know, picking up quite a lot about a lot. When you start as a first year, obviously, you know, you don't know when you're looking at blood results, so you might not appreciate the importance of certain liver function tests, and then you'll go and do your liver placement and you think, oh yeah, loads of light bulbs go on. So definitely you acquire a lot of knowledge, and with knowledge is power, I suppose. What I've learnt is that even though my knowledge base has grown, it's almost, the more I know, the more I realise there is more to know. So I'm never going to know it all, and it's really, really important to ask questions and just, yeah, be comfortable in your own skin, really. I think if someone wanted to become an ACP, I would absolutely, you know, support them and really encourage them to do it. It's a really worthwhile, and I have a massive amount of job satisfaction. I'd say stepping away from your traditional role, you've got to be prepared to do that. So as an intensive care nurse, I was used to, you know, really holistically, not just looking after the patient, but I knew that patient's family, and I was a big part of that patient journey. Whereas as an ACP, it's, you take a bit of a step back. So yeah, if I had to ask my patients, oh, you know, what have I done for you today? They might not have a clear understanding. Some days it's just a matter of doing blood results or chasing investigations, doing the discharge summary. So it's a lot more behind the scenes stuff. So I would say you have to be comfortable with stepping away from your traditional role.
I spent a little bit of time with one of the qualified ACPs, had a look at all the new skills that they'd learned and the things that they'd developed and the knowledge that they'd developed, and I wanted to try and do a piece of that and become more experienced and be able to do more things, really. I think the biggest challenge from being a physio and then going into an ACP role is stepping into sort of a more medical type world and sort of a different sort of culture of learning and experience in the way that people work, and just learning, sort of stepping out your comfort zone is the main thing. Most of the patients start off with think you're a doctor, so you have to explain that you're not a doctor, that you've just come from this physio background, and using the skills that you've learnt as a physio along with your extra training and the knowledge you've gained to be able to do similar sort of tasks but from a different background and a different point of view, really. So using the skills that I already knew as a physio, and then just building on them to be able to do more sort of advanced tasks and advanced assessment of patients. The training program that we're doing at the moment, it's majority work-based learning and experience, with sort of 1 day a week where we go to university and do the master's programme and get the sort of the lectures and the practical teaching, which you then bring back to work to be able to essentially practice and use in a real life situation. I work on the acute medical wards for the elderly, so finding out which ones are the new patients and preparing all the sort of documentation and getting a history from the notes around the new patients that have come in overnight, and then meeting up with the rest of the multidisciplinary team, so the nurses, the physios, the OTs, having a ward round in the morning so everyone knows where the day's going and what the priorities are, and then taking the ward round, working alongside the consultants and the other doctors on the ward round, assessing the patients, working out what needs to be done for the day, and then after the ward round essentially carrying out the jobs that were created from the ward round, so sort of referrals, bloods, chasing up x-rays, referring for x-rays and things like that. So if a physio asked me if they should be an ACP or whether they should think about it, I'd definitely recommend it and consider it as an alternative route sort of through the progression. The benefits are you just get to exposed to lots of different things that you wouldn't normally get exposed to in physio. Lots of new experiences and new skills that you can learn. Sort of not the downside, but the challenges are that it is stepping outside of your comfort zone, and it's you do have to sort of dedicate yourself to it and do a lot of hard work and sort of commit to the long time learning, really. I think if you're going to go into this role, you have to go into it with quite an open mind of where it can take you. I think in certain areas the role is quite defined, but in especially the areas that I'm working, it's a new role, and the doors are open to do a variety of things, and you can sort of guide the role into different areas that you see benefits yourself but benefits the service as well. So go in with an open mind of where you might end up and the things you might do, and don't close doors.
My background is a nurse. I trained in London originally a long time ago, and I originally started in acute medicine and then moved on to intensive care. And I moved from intensive care to children's intensive care with the thought that I would want to be a senior sister within that intensive care environment. And within the paediatric intensive care environment, as I got more senior, I was moving further away from patients, and quite quickly came to the conclusion that managing the unit, managing the staff, managing the whole department wasn't really what I enjoyed, and what shifts that I really enjoyed were when I was looking after babies. So there weren't opportunities at that time for me to be able to go and develop clinically. So when an adult job came up to stay within the clinical field but develop, I made that very difficult decision to move back out of paediatrics back into the adult, or out of paediatrics back into the adult setting. So I became a medical nurse practitioner. And that was the start of my advanced clinical practice role, really. At that time, like I say, we were called MNPs, medical nurse practitioners, and that was in 2001. So that's actually quite a long time ago to be moving into this kind of advanced clinical role in a small district general hospital in Hertfordshire. So I'd stayed there, and we trained for 3 years working within the medical divisions, and then I moved up to Derbyshire, which is where I am now, and continued at that time an ANP role, advanced nurse practitioner role, but was about the only one here, and then over the 12 years that I've been in post here, have gradually embedded the role within the trust to a point where we've got 66, a mix of trained and trainees, but 66 practitioners overall. Because I didn't actually come into an ANP job originally, it was an emergency admission nurse coordinator role, which is some fancy title, but so the role evolved really, rather than it being structured, right, we're going to recruit 6 ACPs, it happened I would be working within an AMP type role on the days that I wasn't doing the emergency admissions work, It worked effectively, obviously, because more came behind me. Consultants and management decided that actually could they have some more people like me, and so we recruited in dribs and drabs, but it wasn't a formalised programme, whereas now in 2011 managed to get a task and finish group developed a framework and a professional assurance framework for advanced practice. And that's probably really the tipping point was 2011, and it really has taken off since then because we've got structure and people have more confidence because there's more understanding about the role. They can actually see what it is that we're doing, and there's competencies that people need to achieve, and the university's linked in with us, so that's their programme has changed to make sure that it's supporting service requirements, rather than it being a full master's with a research-based dissertation. It's a master's in advanced practice with a clinically based final year, which gives us an awful lot more reassurance our practitioners are coming out properly qualified. One of the key points that I'd say to any trust that's going in this direction is there is still a lot of uncertainty. There's an awful lot of questions from clinicians, radiology, from managers, from staff, patients, etc. So you need to have that figurehead that can actually help answer those questions, reassure people. It's signposting people to a person rather than it drifting and getting a million different ideas and nobody really being quite sure. So it's really, really helped to have that direction, I think, and probably why we've got 66 trainees. I don't do a huge amount of direct one-to-one training and supervision. A lot of my work is educating management, consultants and staff about what the role is, what the role isn't, what the expectations should be. A lot of my work's been liaising with the university to make sure the programme's developing as we need it. Keeping on top of developments within advanced practice nationally, so through the HE work, and supporting across the whole region actually. So an advanced clinical practitioner within Derby, actually within Derbyshire, because we've made it regional, or county-wide, it can be a practitioner that's from a registered healthcare background, so they do need to have an initial registration, but that doesn't have to be just a nurse. I know that there's some areas that would only accept a nurse within the role. We very much felt that actually there's no reason to think that it's only a nurse that could actually work in a medical model. So felt that we were missing out on a lot of skill and knowledge if we didn't consider other healthcare professionals. So our ACP trainees, or trained if they are trained, can come from any healthcare background. They have to have at least 5 years qualification from their initial registration. And what we want to see, because these are senior roles, these are people that need to be able to be flexible, embed themselves within both the medical team and within nursing teams within the MDT. So they need to have some leadership, evidence of leadership skill and quality. So we very much have worked hard on trying to recruit for attitude and make sure that we get the right people in post who need to have a capability to study at masters and achieve the masters, but don't have to have necessarily a first level degree, because we've recognised that there's a lot of nursing staff in particular that are maybe a little bit older, that have years of experience and very capable of studying at masters, but didn't have the opportunity to do a first level degree initially. So we work with the university at recruitment stages to make sure that we feel that they would be capable to study at masters. Like a lot of medical model or medical roles that and skills that are being performed by non-medical staff, it sometimes doesn't matter how much you introduce yourself and what you tell a patient. You'll finish a consultation and they'll say, well, thank you, doctor, and which makes most of us laugh, and that's not uncommon. But generally the feedback that we get is very, very positive. Our practitioners are very experienced practitioners. They're very experienced in communication and very aware of patient needs, very aware of quality, and that's not to say that any of our other staff aren't, but they can bring that clinical leadership forward, and that's good for the patient. And generally we get very, very good feedback, both from patients and members of staff, from family members. But it is about working differently within the NHS and probably accepting that it's not just medics that do medicine now, that there's a huge sort of skilled workforce out there that if we choose the right people and we train them effectively, can add very positively to the patient's pathway. So we get an awful lot of inquiries about the ACP role. I think as the numbers grow and the visibility and the critical mass increases, obviously there's more and more interest in the role. So the last 2 recruitment drives that we've had over almost 200 people apply and show interest in these posts, which is really exciting. It's a role that keeps you by the bedside, it's a role that keeps you clinical, but it's hard work, and we really need to stress to people that want to come into the role, it's one of those posts that actually the longer you're in it, the harder it will get, because the more you learn and the more you become capable of doing. And then on top of your baseline profession, you're then adding an awful lot of additional skills and building that portfolio up. So it ends up that you can do huge amounts, and you become a very, very skilled practitioner who has a huge amount to add to a patient pathway. Sometimes it's quite an isolating role. You don't really belong with your original profession as such. You're not embedded within them. You still have those skills, but you're not working directly alongside them every day. But you don't belong within medicine either, and so you're sort of in this middle ground, and it can be quite a lonely place to be. I think within this trust, the fact that we've got so many, we've got a critical mass, and actually it's one big family, and we do try and pull everybody together. And in departments where there's more, so our ED department, it's a bit easier because there's 15. In our specialist medicine, there'll be throughout specialist medicine, but within a ward setting, you might only have 1 ACP, and that can be quite lonely. So it's very important that we keep contact, and it's making sure that people are aware of the vulnerability.